Hi, my name is Rachel Morsch. This is my case connections for Unit 4. So I did case number 1 and case number 3. So we'll start with case number 1. Case number 1 is about a newborn girl that was completely normal at birth, but then about 24 hours after she became lethargic, hypothermic, and apneic. So the attending physician ordered some blood panels and thinks that she has a metabolic disorder. And the physician wants to know, is a blood glucose, a urinary acid, a serum fatty acid, or a plasma glutamine going to be the one that differentiates between a beta oxidation of fatty acid metabolic deficiency or a urea cycle deficiency? We got blood work back and we found out that her ammonia was high, her urine orotic acid was also elevated, and her plasma citrulline level was normal to slightly low. So if she has a deficiency in the urea cycle, which we'll go through, what would be the most likely enzyme to be deficient and what would be the least likely enzyme to be deficient based on these studies? So the patient appears to be suffering from ornithine transcarbamylase deficiency, or OTC deficiency. So it means that she's deficient in the second enzyme of the urea cycle. This enzyme is called ornithine carbamyl transferase. So if we test urinary acids, it would be most helpful in distinguishing if the patient has a problem in beta oxidation of fatty acids or urea cycle, which we'll go through in a moment. So we'll work through each test and see why some tests would be helpful and some tests would not be. So blood glucose is a test that's used pretty commonly in all settings, and it's great for telling us things like, is insulin too high, is insulin too low, are we able to maintain homeostasis and a blood glucose level during fasting states, such as is glycogenolysis working to maintain that blood glucose level. But it's not really going to tell us, hey, is there a problem in beta oxidation of fatty acids versus the urea cycle, because the urea cycle's goal is to get rid of free nitrogen or ammonia in the blood. Urinary acids is the test that I think that we should use. So it has a wide range of results, and depending on the acid that you find that is elevated, tells you, hey, I think there's a deficiency in this particular metabolism. So elevated levels such as glutaric acid, ethylmalonic acid, and dicarboxylic acids tell us that there's an issue with the beta oxidation of fatty acids. So for example, elevated levels of ethylmalonic acid tells us the patient has a deficiency in the enzyme acyl-CoA dehydrogenase, which is found in beta oxidation. Elevated levels of glutaric acid is a result from defects in the transfer of electrons from fatty acid oxidation into the electron transport chain. Meanwhile, elevated levels of orotic acid, which is what the patient has, would be indicative of a deficiency in the urea cycle. This is because the intermediate carbamyl phosphate is also used in pyrimidine synthesis. So if there is a deficiency in enzyme number 2, ornithine carbamyl transferase, that means that we can't take the carbamyl phosphate and create something new. This excess carbamyl phosphate has to go somewhere, and it will go into pyrimidine synthesis, and increased pyrimidine synthesis increases orotate or orotic acid. Serum fatty acids. So serum fatty acids would tell us that lipolysis, or the breakdown of triglycerides into glycerol and fatty acids, is deficient. But it's not going to help us differentiate if beta oxidation is occurring or if the urea cycle is deficient. Plasma glutamine. So if there's a buildup of plasma glutamine, this would indicate to us that there is a deficiency in the urea cycle. This is because we're unable to free ammonium via glutaminase. So glutaminase frees ammonium from L-glutamine, creating L-glutamate, and then obviously the ammonium ion, which then goes into the urea cycle. But it's not going to differentiate between beta oxidation and the urea cycle. So obviously, like I stated, the enzyme most likely deficient is ornithine carbamyl transferase, which combines carbamyl phosphate and L-ornithine to create L-citrulline, which is then transferred into the cytosol to continue urea cycle to create ammonia, or urea, excuse me. So if this is deficient, carbamyl phosphate builds up, goes into pyrimidine synthesis, and increases orotate or orotic acid. So the enzyme most likely to not be deficient is the first enzyme in the cycle, carbamyl phosphate synthetase 1. So this enzyme combines ammonium with carbon dioxide to make carbamyl phosphate. Obviously, if this was deficient, then we wouldn't have a buildup of carbamyl phosphate. We'd have a buildup of ammonia, but none of the other intermediates in the urea cycle. So this is the one that's most likely to not be deficient. Case number 3. So case number 3 is about a 47-year-old male with no past medical history that we're aware of or told of that comes with signs and symptoms of gout. So he is diagnosed with gout, and they do a urinalysis, and they find out that his plasma urate is high and his urinary uric acid is low. So we want to know which of the three mechanisms is causing his gout. Is it an overproduction of purines, a decreased salvage of purines, and a decreased urinary excretion of uric acid? So just to overview, if you do not excrete the purines or salvage the purines, you have a buildup of uric acid, which causes a lot of pain in the joints and crystallizes, causing the signs and symptoms of gout. So the best explanation that I believe for the presentation of gout in this patient, based on our tests and our current knowledge of the patient and his medical history, is a decreased urinary excretion of uric acid. So we would like, if possible, to have a more thorough past medical history on this patient, as well as a blood panel that includes lactic acid and creatinine to help us differentiate this. But let's go over the options and deduce why I believe this based on the information that we have. So overproduction of purines. It's usually characterized by a metabolic disorder, which often occur in childhood. Diet can also increase the number of purines created, such as if you have a high intake of red meats, alcohol, or fructose. So von Geurk's disease, or G6 taste deficiency, is an example of a disorder in purine overproduction. So in this disease, there is deficiency in the enzyme glucose 6-phosphatase. This enzyme hydrolyzes glucose 6-phosphate into a phosphate group and free glucose. If this enzyme is deficient, then it builds up to a buildup of glucose 6-phosphate in the cell. This is then oxidized through the pentose phosphate pathway and increases production of ribose 5-phosphate. An increase of ribose 5-phosphate leads to an increase in nucleotide production. Von Geurk's disease is an autosomal recessive disorder, and these patients are sick from birth. So they are hypoglycemic, they have lactic acidosis, they have hepatomegaly or enlarged liver. They're easily bruised, they can have hyperlipidemia and hyperuricemia. Gout usually presents early at puberty since they've been sick since birth. And since this man is 47 and we're not told of any other medical history, I don't believe that it's this, which means I don't believe it's an overproduction of purines. Decreased salvage of purines. So this is definitely caused by metabolic disorders. So this means that we cannot salvage a purine or take the parts away from it that we can then recycle back into other metabolic processes. So Leishman syndrome is an example of one of these disorders. It's a rare metabolic disease. It's X-linked. It's a deficiency in the enzyme hypoxanthine guanine phosphoribosol transferase, which recycles purine so the bases can be utilized in the body. Without this enzyme, the body can't salvage purine nucleotides, and this results in the buildup of uric acid. So these children appear normal, but then after 3 to 6 months, they begin to get sick. So they have developmental delays, they have neurological issues, which we're really not sure why they're caused. They can also become mentally retarded, have self-mutilation of their lips and their hands, and they're aggressive and they're compulsive. So once again, since this man appears to be normal from what we're told, we're not told anything otherwise, I don't believe that he's having any signs or symptoms of a decreased salvage of purines, and the test results don't tell us that either. So decreased urinary excretion of uric acid. So it appears to be our correct answer. Multiple things can cause this, but it relies on the fact that our liver and our kidneys are not excreting the uric acid at a proper pace to maintain homeostasis. This high plasma urate is showing us that the patient has an increase in uric acid in the bloodstream, and the low urinary uric acid shows that he's unable to excrete it properly. So these tests are common tests that are done by physicians in the process of diagnosing if this patient has gout or if there's something else going on. Also, excessive sugar intake, high fructose corn syrup intake, and alcohol intake can overload your liver. So excessive fructose leads to an increase in purine synthesis, which we'll talk about, and excessive alcohol intake leads to lactic acid formation, and that lactic acid then fights with the uric acid for excretion via the urinary bladder. So also the patient tells us that he decided to switch to diet soda, which includes high fructose corn syrup, which includes high fructose corn syrup, and that high fructose corn syrup is a mixture of fructose and glucose, but more highly fructose. So fructose, as I mentioned a second ago, leads to an increase in purine production, but how does it do this? So it occurs because D-fructose is broken down into fructose 1-phosphate and an ADP, because to be able to do that, you have to put an ATP in, and you get down an ADP. So this ADP can then be transformed into AMP by nucleotidase, and AMP can be transformed into IMP by AMP deaminase. So this IMP can then be transformed into inosine by nucleotidase again, with the addition of water and removal of phosphate, and this can eventually be transformed into uric acid after a series of other reactions. So I believe this patient definitely has a decreased excretion of urinary uric acid, partially because of the fact that he has such a high influx of high fructose corn syrup. So this increased production of uric acid leads to the symptoms of gout, which includes sudden pain, swelling, redness, and tenderness to the joints. Thank you for your time.